Hi everyone, and welcome to this lecture on the spinal cord and spinal nerves. This is what we're going to be talking about today. We're going to start by having a quick overview about the spinal cord and where it is located. Then we're going to talk about the external anatomy of the cord and moving on into defining how the cord is defined into segments and spinal nerves. We're then going to look at those meningeal coverings again that protect the spinal cord. We're going to look at the blood supply. Then we're really going to delve deeper into that internal cross-sectional anatomy. Then we're going to move on to talk about the spinal nerve and how the spinal gray matter is organized. We're lastly going to finish off by touching upon the location of those major pathways that bring information from the brain to the cord and from the periphery using the cord towards the brain. So let's go back to this slide which we've seen before, which talks about the subdivisions of the nervous system. And so far we've spent a great deal of time talking about the brain, which is part of the CNS, and today we're going to talk about the spinal cord, which is also part of the CNS. But it is that spinal cord that will use those peripheral spinal nerves to link the CNS with the body itself. So we're going to transition on today's lecture from talking about the spinal cord into a bit of a discussion about the peripheral nervous system, how the spinal cord links to the periphery. We should know that the peripheral nervous system consists of the somatic nervous system, which is controlled by us and we perceive it consciously, such as the actions of our voluntary movement, as well as what we are feeling through our skin. So this is what we call the somatic nervous system. We are conscious of what's happening in our external environment. This is in opposition to the other division of the peripheral nervous system, the autonomic nervous system, which is under involuntary control. It controls the activities of our internal environment, such as our organs, our smooth muscle, and our glands. And we have the sympathetic and parasympathetic divisions within it. So just a quick review on our terminology. Remember that any neuron consists of a cell body and an axon, which can be myelinated. So if we have many cell bodies grouped together, we have distinct terminology. Depending on whether we are in the CNS, we can have the cerebral cortex, so that heavily folded cerebral surface. So we know that we have those cell bodies collected in there. We also know we have distinct gray matter structures from deep within the cerebrum, such as the thalamus and those basal nuclei. And as well, in the CNS, in the spinal cord, you're going to see that gray matter is confined to the inside of the spinal cord. Now, when we talk about the peripheral nervous system, a grouping of cell bodies, we're going to call them ganglia, or a ganglion for one single one. So these cell bodies in the periphery tend to group together as masses, as ganglia. In terms of the white matter, when we are in the CNS, we can group those bundles of axons into what we call tracts, fascicles or fasciculus, pathways, lemniscus. There are many different terms that mean the same thing. So I want to reassure you not to worry too much. These terms, we're going to mention them, but they all mean collections of white matter fibers in the CNS. In the PNS, it's very simple. We simply call these collections of axons as nerves. Okay? Now, of course, if we talk about the spinal cord, we need to mention the vertebral column, because it is this vertebral column composed of about approximately 33 bones, which houses and protects the spinal cord. Okay, so you learned about the anatomy of this vertebral column, all of the bones, the typical anatomical landmarks of each of the types of vertebrae, how they stack on top of each other to give us those intervertebral foramina, and it is through there where the spinal nerves are going to be emerging. And the spinal cord is really inside this vertebral canal. So I'd like you to spend a couple of seconds looking at this image here. This is a sagittal MRI. So we have the brainstem here, the cerebellum here, and we can follow the region where the spinal cord is located, where those white arrows are. And try and think about, what do you notice about the spinal cord with respect to the vertebral column? So hold this image in your mind as we go through the lecture. It will hopefully become obvious in the next couple of slides. So let's start by giving an overview about the spinal cord. So it is part of the CNS, okay, part of the central nervous system. Where does it start? Where does it end? Well, it is continuous with the medulla oblongata. So here is the brainstem, here is the medulla oblongata, and the spinal cord is continuous with it at the level of the foramen magnum. Okay, so the spinal cord continues going down, housed inside that vertebral canal, but it's actually going to end at the levels between the L1 and L2 lumbar vertebrae. So this termination of the cord, we refer to it as the conus medullaris. This spinal cord, as we can see, gives rise to all these different spinal nerves that leave through that space between each vertebrae. Those nerves are peripheral nerves. So the spinal cord, as we were saying, serves as a pathway to conduct information between the brain and the body. It's also going to act as a reflex center. And in this cross section here, we can also appreciate that anatomy. So this is the vertebral body anteriorly, the spinous process posteriorly. We can see that spinal cord inside that vertebral canal. We can see how it gives rise to pairs of spinal nerves. So these are dorsal views of the spinal cord. So we have a cartoon image and a corresponding cadaveric image. We can see one more time how at the level of the foramen magnum, so this is one occipital, this is one piece of that occipital bone that has been cut, and here's the other side. That would be that foramen magnum. That's where the brainstem becomes continuous with the spinal cord. Okay, so that spinal cord, as we mentioned, gives rise to those dorsal roots of spinal nerves, and we can see them as well in the cadaveric view. If we follow that spinal cord, we can see how it ends at that conus medullaris between the L1 and L2 vertebrae. However, nerves, spinal nerves, keep emerging from those lower levels of the cord, those as longer strings, longer nerves to leave below their respective intervertebral foramina. So those long collections of nerves that keep leaving the cord are called the coda equina. Okay, so the reason these nerves are called coda equina, those collections of nerves, is because they resemble a horse's tail. So you can also think of this as a horse's tail. Coda means tail, equina means horse. So let's keep discussing that gross anatomy of the cord. So one more time here, this is the brainstem, and it's transitioning to become the spinal cord at the level of the foramen magnum. So what we're going to notice is that the cervical level of the spinal cord is enlarged, is thicker. The thoracic cord is quite thinner, but then it enlarges again at the lumbar level, and we're going to see why that happens. So if we focus on this caudal region of the cord and we expand it, here we can see that lumbar enlargement, and we can see really clearly that termination of the cord as the conus medullaris. You can also see very clearly those long nerves that keep emerging to form that coda equina. Let me tell you about this tiny little structure here, which extends from the tip of the conus medullaris all the way down to insert into the coccyx. This structure is called phylum terminale, and it provides an inferior attachment for the spinal cord. So it secures it into that coccyx to prevent excessive movement of the cord. We can also appreciate what's been open here to expose the cord. Well, it is the dural sac. We know that the spinal cord is covered by meninges, those meningeal layers. So we need to open those sacs of meninges, that dura, and on the undersurface, that would be the arachnoid, to expose the spinal cord. And you can start to notice how that dural sac extends lower than the termination of the cord. So it can encompass, it can include those cauda equina nerves. What do we have on the underside of the dura? The arachnoid. What do we have underneath the arachnoid? The subarachnoid space. What's inside that space? CSF. So inside all of this region, inside this dural sac, this is all filled with CSF in the living. So those cauda equina nerves are suspended in CSF. Okay, so from the point where the conus medullaris ends and extending towards the end of the dural sac, we've now have the lumbar cistern with CSF. So let's look at those regions of the spinal cord. Well, the regions of the cord are defined by the pairs of spinal nerves that each of them gives. So we have 8 cervical spinal nerves, therefore we have 8 cervical spinal cord segments. We have 12 thoracic spinal nerves, 5 lumbar spinal nerves, pairs, they're all paired, 5 sacral spinal nerve pairs, and 1 coccygeal spinal nerve pair. We know the ending of the cord is around L1 and L2 vertebrae. From there we have all those cauda equina nerves that keep coming down, extending from the cord to leave below the next couple of vertebrae. So we can see that we have 31 pairs of spinal nerves. Therefore, we have 31 segments of the spinal cord. Remember, they're all part of the PNS. So let's focus on this region here, that ending of the cord, that conus medullaris between L1 and L2. The dural sac, as I was mentioning earlier, however, extends all the way to S1, S2. And in between, we have the lumbar cistern. So this dural sac is filled with CSF, and we call this region the lumbar cistern. We can also see that filum terminale extending from the tip of the conus medullaris all the way down to attach and secure that spinal cord into the coccyx. Okay, so what we're going to be doing now is looking at that relationship between the spinal nerves and the vertebral levels. So we can again appreciate how the cervical region of the cord is thicker, as well as the lumbar region of the cord is thicker. Why are they thicker? Let's focus on the cervical region. And we can see that cervical enlargement here. Why is it thicker? Well, if we think about it, in the cervical region is where we find all the cell bodies, all those motor neuron cell bodies that are going to innervate our upper limbs, including all those collections of nerves that are going to go and form the brachial plexus. Okay, so it needs to be thicker. We have high, intricate motor control over our upper limbs. We need lots of neurons to go there. The thoracic spinal nerves, well, they innervate major muscles, yes, the abdominal muscles, some back muscles, but these muscles don't perform such intricate movements like our upper limb does. In terms of our lumbosacral enlargement, well, you can predict why it's thicker as well. This is because we have those motor neurons arising from the cord that are going to innervate the lower limbs. So as part of this, emerging from this, we're going to have those nerves that form the lumbosacral plexus. And again, emerging from just the lower levels of the cord, we have those cauda equina nerves. Okay, so even though the spinal cord ends at L1, L2, those nerves that are going to leave the sacrum, they still extend and leave respectively in the sacrum. Okay, so that coda equina contains the roots of the lower lumbar, sacral, and coccygeal nerves. Let me go back here on this focused image at the cervical enlargement. And I told you that we have 8 cervical spinal nerves. But you know from your knowledge on the vertebral column that there's only 7 cervical vertebrae. How come? Well, the C1 spinal nerve can only leave from above the C1 cervical vertebrae. We can see that the C2 nerve leaves above the C2 vertebrae. The C8 nerve leaves above the T1 vertebrae because we don't have a C8 vertebrae. But at that point, we have a transition point in which the nerves now are going to come below their corresponding vertebrae. So the T1 spinal nerve is going to leave below T1, T2 spinal nerve below T2, and so on and so forth. So let's illustrate that a bit differently. So here we have 3 vertebrae stacked. We have those intervertebral foramina. And let's pretend that we are at the level of C6, 7, and T1 vertebrae. So we can see that just above C7 we have the C7 spinal nerve. Just above T1 we have the C8 spinal nerve. Okay, only 7 cervical vertebrae but 8 spinal cervical nerves. And that's where we have the transition point, because from T1 onwards those nerves are going to leave below their corresponding vertebrae. So we can see T1 leaving below T1. T12 leaving below T12, L1 leaving below L1, L2 leaving below L2, and so on and so forth. Let's go back to those meninges now of the spinal cord. So we've seen this before. We've seen how the spinal cord is covered by the same meningeal layers that cover the brain in the cranial cavity. And we've seen this view. This is a cadaveric view where again that dural layer and arachnoid have been opened to expose the spinal cord. So we know we have the pia, we know we have this translucent spider's web-like arachnoid, and we have the tough dura mater. We know that in that space between the dura and the arachnoid, we call it the subdural space, which is a potential space. And just underneath the arachnoid and between it and the pia, we have the subarachnoid space, which is real because it's filled with CSF. We have those denticulate ligaments, which are extensions from the pia, lateral extensions from the pia, and what they do is that they secure the spinal cord on each side, so laterally through the arachnoid and through the arachnoid to the dura. So they are lateral attachments of the spinal cord, again to prevent excessive movement. Those denticulate ligaments, we find them interspersed between those spinal roots, spinal nerve roots. So if we look at the anatomy of a spinal nerve, and we're going to talk about it in detail in a few slides, we can see how as the spinal nerve roots leave the cord, they take with them a layer of meninges. So here the spinal nerve is taking with it a layer of arachnoid as well as a layer of dura. So what these meningeal coverings around the spinal nerves are going to become is a structure, a protective tissue called the epineurium. Okay, this is the name we give to that protective layer surrounding each spinal nerve. And now we know that it originates from those meningeal coverings. So let's talk now a little bit more about that spinal dura versus the cranial dura. So in this cartoon image, this is the cranial cavity without the brain and the vertebral canal without the spinal cord. We already know that in the cranial cavity, the dura is composed of 2 layers. The periosteal layer of the dura, which is in contact with the bone and in contact with the other layer, the meningeal layer of the dura. So we have 2 layers. and there's no separation between them at any point. Only at specific points. There are some exceptions where the meningeal layer protrudes to give us our falx cerebri tentorium and falx cerebelli. But normally there's no separation between the two. What can we see here? We can see that it's only the meningeal layer that is going to continue through that foramen magnum to line the inside, or actually the outside of the spinal cord. So there is no periosteal dura at the level of the spinal cord, only the meningeal dura. We do have a real epidural space between the vertebrae and that dura mater, and it's filled with fat. Okay, so this was in opposition, very different from the case in the cranial cavity. I'm going to spend some time now telling you why the spinal cord ends before the vertebral column ends. And this is due to differential growth of the vertebral column as we grow. So let's look at that relationship between the spinal cord and the vertebrae, vertebral column in the fetus, around 2 to 3 months old fetus. So we can see that the spinal cord is actually extending all the way along the length of the vertebrae. Let me bring your attention to this S1 vertebrae, and this is the S1 spinal nerve root. So it's exiting near the level of origin. This pink structure covering the cord is that dura mater. So if we look at the relationship at birth, we're going to understand that the vertebral column is going to grow faster compared to the spinal cord. So that spinal cord is actually going to regress and ascend upwards. That termination of the cord in the fetus is going to remain, so this region is going to remain attached to the coccyx as what we know as the filum terminale. So there's just a really thin string of neural tissue. So in the at birth, the spinal cord, that conus medullaris, ends around the L3 vertebral level. And we can start seeing now how that sacral nerve root, it's now near those lumbar regions. However, it still extends all the way down to leave below S1. We know that we have that lumbar cistern filled with CSF. Now, in the adult, so when we keep growing, the vertebral column keeps growing faster compared to the cord, so the cord keeps ascending a bit more, such that in the adult, the spinal cord is going to terminate between L1 and L2. And look again at this sacral S1 spinal nerve root. Okay, so it is those lower lumbar and sacral nerves that extend down as the coda equina to reach their corresponding vertebral levels of exit. We have that space, that lumbar cistern filled with CSF, and we can see how that filum terminale keeps extending all the way down to secure the spinal cord inferiorly at the coccyx. Okay, so the take-home message is that there is differential growth between the vertebral column and the spinal cord, such that the vertebral column grows faster, and because of that, the spinal cord ascends within that vertebral canal. So if we look at that relationship between those spinal cord segments and the vertebral level, we're going to see that there is increased disparity as we reach the lower levels of the cord. So if we're here in that first cervical spinal cord segment defined by the first pair of cervical spinal nerves, we see that the first cervical spinal nerves leave just very close to that spinal cord segment. As we start reaching the thoracic vertebrae, we can see that the thoracic spinal cord segment here, that thoracic spinal nerve descends a little bit to leave below its corresponding vertebrae. And as soon as we reach the lower levels, it is those lumbar and sacral nerves that have to travel quite a long way to leave below their corresponding vertebrae. So we still have a sacral spinal cord segment, even though it is behind those lumbar vertebrae. Why is it still sacral, called sacral? Because it gives rise to the sacral spinal nerves. So here we have another view of that cauda equina. So we can see that it's really those lower lumbar, sacral and coccygeal nerves that travel through that cauda equina, traveling through that lumbar cistern to reach below their corresponding vertebrae. So we can see that as well in this dorsal view. And it is thanks to this cauda equina that we can perform such procedures such as the lumbar puncture. So, what do we have here? Let me tell you about that lumbar puncture, also called the lumbar tap or spinal tap, and I will also tell you a bit about the epidural anesthetics. So let's start with that lumbar puncture. So this illustrates the surface anatomy of a patient that is lying on their side, knees to chest position, and it's illustrating the insertion of the needle in order to obtain a sample of CSF. So that procedure is called a lumbar puncture. So we need to insert the needle way below the spinal cord has ended. Okay, we do not want to puncture the cord. So where does the spinal cord end? Well, we know it's generally between L1 and L2. Because of anatomical variations, it could be that the conus medullaris extends all the way to L3. So in order to be safe, the needle needs to be inserted anywhere below L3. Okay, it needs to go below L3. So you're going to see some textbooks mention between L3 and L4, other textbooks mention between L4 and L5. It doesn't matter. We need to go below L3 to be safe. Okay, so the needle is inserted below L3, and we know there that we are in that lumbar cistern where we can take some CSF sample out. It is that cauda equina that allows us to do this. Because of that cauda equina, the nerve roots are simply just going to move away gently, harmlessly, when the needle is inserted. Think about inserting a needle in a bowl of spaghetti. All those spaghetti are just going to move away. Okay, it's really rare that you're going to puncture one. Even more rare, puncturing those nerves of the cord, leaving the cord. Okay, so thanks to that cauda equina, we can perform this procedure. A lumbar puncture is not indicated in cases when there is increased intracranial pressure. Because if there is increased intracranial pressure, as soon as you insert the needle, the CSF is going to escape as a jet. Okay, so we're going to create a pressure differential between the pressure in the cranial cavity and the pressure in the spinal cord, and that brain can herniate. We can have, for example, a tonsillar herniation through that foramen magnum. So it needs to be checked by performing a CT scan whether someone has increased intracranial pressure. You can also look at their eyes to make sure there is no papilledema or inflammation of that optic nerve. Okay, so now we know the position of the lumbar puncture. We know ideally the patient would be lying on their side, knees to chest, or it can also be done with the patient sitting down and arching over towards their knees. The reason we prefer one of these two positions is because as the patient bends their back, that's going to stretch the ligaments between the vertebrae, specifically this ligamentum flavum that connects the vertebrae, so that there's more room to insert the needle. The needle is going to be inserted through that ligamentum flavum, and you're going to hear a popping sound. Pop. As soon as you hear that popping sound, you know you you have entered the lumbar cistern and you can extract that sample of CSF. A sample of CSF can be attained for many diagnostic purposes. So for instance, there should normally be no blood cells within the CSF. So if you find any blood cells, that might indicate a subarachnoid hemorrhage somewhere. You can also analyze the cell composition of CSF, and that can tell you whether there's an infection such as meningitis. Sometimes you can also puncture that space to inject specific medications and drugs. So now we can talk about other needles that we can insert. And you may have heard of that epidural anesthesia or just epidural blocks. Well, the name tells us where this procedure is aimed at anatomically. Epidural. What do we have in that epidural region? That region above the dura, upon the dura, external to the dura. Well, we have epidural fat. So all of this fat in that epidural space. So in that region is where you're gonna insert a needle to inject that anesthetic. So you still puncture the ligamentum flavum, but you are not gonna go as deep. Okay, only into that epidural space to insert the anesthetic. You must be aware that if you insert that anesthetic at this level, anything below here on down is going to be anesthetized. So including if we are here between L2, L3, we might anesthetize motor functions of the limbs, and any sensation coming from the limbs the patient won't feel. Another popular region, especially for childbearing women, to decide if they decide to get an epidural anesthetic when before giving birth, is to insert that needle at the region of the sacral hiatus. So we can still reach some epidural fat there, reach that epidural space there, and insert that anesthetic. So that's only going to numb those nerves around the perineum. We can now look at that vasculature of the cord. So we can define some anatomical regions of that spinal cord. So we have an anterior median fissure, which is quite deep, and a posterior median sulcus posteriorly. We can also have lateral to those a posterolateral sulcus as well as an anterolateral sulcus. These anterolateral and posterolateral sulci mark the origin of those ventral and dorsal spinal nerve rootlets. But they're also going to mark the position of, all of these are going to mark the position of some blood vessels. So we've talked about the anterior spinal artery, which is typically a branch, well, it is a branch of the vertebral arteries, and it descends all the way down to supply the anterior aspect of the cord in that anterior median fissure. You can see how it sends some branches to supply those deep white and gray matters. We know that we have two paired posterior spinal arteries, also typically arising from that vertebral artery. And we find them at the level of the posterolateral sulcus, again sending some deep branches to the white and gray matters of the cord. But these anterior and posterior spinal arteries, they need help, they need reinforcement. So they are reinforced by what we call a segmental spinal artery. And this segmental spinal artery can be a branch of, depending where we are in the spinal cord, of any of these arteries. So if you're closer to the upper neck, this segmental spinal artery is a branch of the vertebral artery. If you are in the thorax region, it's going to be a branch of the posterior intercostal arteries. So it's a branch from one of these. So this segmental spinal artery is going to approach the cord laterally. As it does so, it's going to send this medullary branch, which is going to be reinforcing that anterior spinal artery in the more anterolateral aspects of the cord. And also it's going to give rise to these anterior and posterior radicular arteries, which supply the blood supply to those spinal nerve rootlets. So this is a point where if you wish to pause the video, you can, because from here on now we're going to be looking at that internal gray and white matter of the spinal cord. I will certainly take a sip of water now. Okay, so this next part of the lecture is really exciting. So we're going to start understanding that internal cross-sectional anatomy of the cord. So if we take a coronal section through the brain, as depicted here, you can see how that gray matter is generally confined to the outside, okay, with some deep collections of gray matter, and that white matter is underlying that gray matter. Now, if we take a cross section through the spinal cord, as we can see here on the left, I want you to note that the gray matter in the spinal cord is confined to the inside of the cord, whereas the white matter is confined to the outside of the cord. So we're going to focus on this cross section, and we're going to give each of those gray and white matter regions names. So let's start with the gray matter, all of this inside aspect here. So the dorsal most aspect of the gray matter, we're going to call it the dorsal horn of the gray matter. So this is the dorsal aspect, okay? This is where many synapses are going to occur, mainly of sensory information. So sensory neurons are going to come and synapse here. We're also going to have a lateral gray horn, but this lateral gray horn only exists between the T1 and L2 levels of the cord and the S2 and S4 levels of the cord. This is going to form the origin of preganglionic visceral motor neurons of the sympathetic and parasympathetic nervous systems. The ventral gray horn, here ventrally, contains the motor neurons, somatic motor neurons that are going to go and innervate our muscles. Let's look now at that white matter. So dorsally, we have what we call the dorsal white columns on either side of the midline, so here and here. Laterally, we have the lateral white column, and ventrally, we have the ventral white column. We have this other extra piece of white matter called the ventral white commissure. And I hope you know from its name, commissure, what it allows is for communication between the right and left sides of the cord. So it allows for crossing fibers from here to there, from there to here. So here is just another representation of the same. So here we have that cross section, and here what we just have is a cartoon illustration of that spinal cord with the gray matter inside and the white matter outside. So the reason I'm showing you these is because as we move on through the course, we might use these cartoon images to start drawing some of the regions of the cord and pathways that cross it. We can see that tiny little central canal of the spinal cord continues with the central canal in the medulla. So just a review of this terminology. Remember that when we're talking about an afferent fiber is when we bring information from the periphery to the CNS. Okay? Afferent, to the CNS. So they're typically sensory neurons. When we talk about the term efferent, we're talking about information going away from the CNS. So from the CNS to the periphery. And they're typically motor, efferent fibers. So we're going to be talking about those spinal nerves now, okay? Because now this is how we're going to link that CNS, that spinal cord, with that PNS, that spinal nerve. So here we have some spinal cord segments with their spinal nerve pairs, and we're just going to focus on this region here. So each spinal nerve starts as a collection of ventral rootlets, leaving that anterolateral sulcus, and dorsal rootlets, leaving those posterolateral sulci. The rootlets are going to merge to form roots. So the ventral rootlets are going to merge to form the ventral root, and the dorsal rootlets are going to form the dorsal root. It is important to note that the dorsal root is associated with the dorsal root ganglion. Okay, and from our terminology, we should know that this dorsal root ganglion is composed of a collection of cell bodies. And I will tell you now, these cell bodies belong to primary sensory neurons, which are the ones that are going to use the dorsal root and rootlets of the cord. So finally, the ventral and dorsal rootlets are going to combine to form a segmental spinal nerve. So this is the anatomy of a segmental spinal nerve. So if we dissect that anatomy of that segmental spinal nerve, and we're now going to be looking at the fiber types that can travel through that segmental spinal nerve. So again, we have our cartoon cross-section through the spinal cord with the white matter on the outside, the gray matter on the inside. We have our dorsal gray horn, lateral gray horn, ventral gray horn. We have the dorsal, here we have the dorsal root ganglion, dorsal rootlets, dorsal root ganglion, dorsal root, ventral rootlets and roots of the spinal nerve. Finally, we have that spinal nerve. So it is those afferent fibers, those sensory fibers, they can be somatic or visceral, that use the dorsal, they travel in that spinal nerve, but then they segregate to the dorsal root of division of the spinal nerve to enter the dorsal horn of the spinal cord. And these fibers have their cell bodies in the dorsal root ganglion. Now, from the ventral horn, from the ventral gray horn, we have cell bodies of motor neurons, somatic motor neurons, that leave the cord. So they are efferent fibers. They leave the cord. They use that ventral roots and rootlets of the nerve to exit the cord and join that spinal nerve. So we can start seeing how the spinal nerve contains mixed fibers. What happens at the level of the lateral gray horn? Well, that's where we have the cell bodies of preganglionic visceral motor neurons from our autonomic nervous system. And these axons, so the cell bodies in the lateral gray horn, but the axons are sent out of the cord by using the ventral root as well. So we can start appreciating the anatomy of a reflex arc. So a reflex arc happens at that same level of the cord or brainstem. The information doesn't really have much time to travel all the way to the brain. So you may be aware that if you touch a hot object, in this case some fire, there's really no time for that information to be sent to your consciousness and for you to say, okay, I'm touching a hot object, for your brain to say that you're touching a hot object, this is dangerous, I'm going to send a response all the way back down to the tip of my finger and remove my arm from there. No time for that. So a quick response needs to happen, and that quick response is going to happen at the level of the spinal cord at what we know as a reflex arc. So let me explain that reflex arc using this example. So this person has touched a hot object with their finger. So these sensory neurons, afferent with an A neurons, are going to be traveling towards the CNS using that spinal nerve, using that dorsal aspect of the nerve with their cell body in the dorsal root ganglion, using the dorsal root to enter the dorsal horn of the spinal cord. In that dorsal horn, they're going to connect synapse with an interneuron. We talked about these interneurons in lecture 1, which can be used to link afferent to efferent. So this interneuron is going to relay that information to the efferent fiber, the cell body of that efferent neuron, which is going to leave that ventral horn, use the ventral roots of the spinal nerve, join that spinal nerve, and go towards the periphery to the muscle it innervates, and that muscle is then going to contract to withdraw that body part from the painful stimuli. We do need to talk about the spinal cord in sections because we are going to need to recognize the levels of the cord from different cross sections. So here we have a section through the cervical cord, a section through the thoracic cord above T6, and a section through the lumbar cord. So what are some anatomical differences? Well, white matter increases as we ascend the cord. Okay, so the cervical cord is going to have the most white matter all over, and that's because increasing fibers from our sensation are going to be joining. So the information from our legs travels in the lumbar cord, also in the thoracic cord, also in the cervical cord. But at the cervical cord, we're also going to find fibers that came from the trunk, from the upper limbs. Okay, so increasing fibers relaying information from all over the body, trying to reach the brain. The gray matter also has some anatomical differences. Basically, that ventral gray horn is larger in the cervical regions and in the lumbosacral regions compared to the thoracic regions. And we already know why, because we have more cell bodies of motor neurons leaving from the cervical cord to innervate the upper limb, as well as more cell bodies of motor neurons in the lumbar and sacral cords to innervate those lower limb muscles. Okay, so that's why we have those cervical and lumbosacral enlargements. The ventral horn of the thoracic cord is quite small. We also know that we only have a lateral horn if we are between T1 and L2 or S2 to S4. So that might help us as well to know where we are in the cord. Last but not least, if we focus on this as thoracic cord above T6, anywhere in the cord above T6, we're going to have two dorsal columns on each side of the midline. So this is the midline here. So we're going to have a gray cell fascicle and a cuneate fascicle lateral to that. So we have two dorsal columns. So again, on this side, we have a gray cell fascicle and a cuneate fascicle. If we look below T6 here, we only find one dorsal column, which is that gray cell fascicle in the lumbar cord and below T6. If we go to this cervical cord, of course, we are above T6, so we're going to find that gray cell fascicle medially and that cuneate fascicle laterally. So we can see there's a tiny sulcus, a tiny division demarcating the two. Okay, so the gray cell fasciculi or fascicles, they extend throughout the level of the cord medially, but the cuneate fascicles only exist above T6. I hope that these names ring a bell, because if we look at that dorsal view of the medulla oblongata, we talked about these gray cell fasciculi and cuneate fasciculi. The gray cell being just lateral to that posterior midline and expanding as the gray cell tubercle, and similar the cuneate fascicle or fasciculus a bit more laterally expanding as the cuneate tubercle. We talked about it in cross-section as well, so that if we look at this cross-section here, underlying those tubercles, those gray cell and cuneate tubercles, we're going to find nuclei. Okay, the gracilis nucleus and the cuneate nucleus. Okay, and that's where some synapses are going to occur between the axons traveling in those fasciculi. Remember, a fasciculus is a collection of axons. So those gray cell and cuneate fascicles, they bring ascending sensory information all the way up towards the medulla, and finally those axons are going to synapse with those nuclei. So we're going to understand at the end of this lecture and the next lecture what these structures do. So I will leave you this image for you to think and tell me whether it is above or below T6 and which level does it correspond to. Is this a cervical section or is this a thoracic section? Is it above or below T6? Next time we're live together, we can discuss it further. So that gray matter in the spinal cord, all of this inside gray matter, it can be regionally divided into specialized lamina. So Rexed in 1952 organized the regions of the gray horn into lamina. So we call them Rexed lamina, based on the cellular composition at each of these levels. And of course, that correlates with function. So if we, you don't need to worry too much about this table at this point. If I want you to remember a specific lamina, I will tell you at the given time. But what's very interesting is that it is where sensory and motor connections happen, basically. And so we know that the dorsal horn is important for sensory connections, as I mentioned earlier. So depending on which modality, which sensory modality those fibers are carrying, the synapses are going to occur at different levels here. So one example, if we're talking about a fiber carrying pain and temperature, so that fiber is going to enter that dorsal root and it's going to synapse in those lamina number 2 with pain and temperature neurons. If those fibers are carrying general sensory information, they're going to synapse a little bit deeper. Let's look at dose number 9. What is number 9? Well, if we read at those number 9 sections of the table, we can see that it's just motor neurons. And depending where we are in the cord, it's motor to different structures. So here is where we have those cell bodies of motor neurons that we know are then going to leave ventrally. Okay? So the gray matter of the cord is highly organized into lamina. I do want you to know for now about this structure here, this Lissauer's tract or tract of Lissauer. And what this region is where those sensory fibers are going to use to enter the cord. Okay? So I like to refer to this region as the region that caps the dorsal horn. So the sensory neurons that enter here, they travel briefly in that tract of Lissauer to then synapse in their corresponding lamina of gray matter. Last but not least, this slide here is quite important. It's going to mark our transition into the next couple of lectures where we're going to discuss the locations and functions of each of these pathways. So if we look outside that gray matter, we are in the white matter, the dorsal columns, lateral columns, and ventral columns. And it is in those regions where we're going to find specific tracts in the spinal cord. So at the level of the dorsal columns, we find the gracile fascicles running the whole length of the cord. And if we are above T6, we find the cuneate fascicles. These fascicles are going to be responsible for carrying ascending sensory information such as fine touch, vibration, pressure, joint position sense from the body. Okay, and the term we use to refer it as the joint position sense is called proprioception. This is the sense that tells us where our joints, our limbs, where they are in space. So that information is carried by the dorsal columns. On the lateral white matter, we have the lateral corticospinal tract. this tract is going to carry descending motor neurons, so the axons of descending motor neurons for voluntary control of our muscles. We also have a smaller corticospinal tract called the ventral corticospinal tract in the anterior white matter of the cord, or ventral white matter of the cord, also carrying descending fibers for motor control. Lastly, we have these spinothalamic tracts, which extend from the ventral region of the cord a bit laterally. So these spinothalamic tracts on each side, they also carry ascending sensory information, but in this case from crude touch, pain, and temperature. So from these modalities. Okay? And I want you to start thinking how you can see that there are some areas that are heavily shaded or heavily colored, and they carry information from a specific side of the body. So in this case, these dorsal columns carry information from the right side of the body, and these lateral corticospinal tracts carry information for the right side of the body. But this spinothalamic tract located on the left side of the cord carries information from the right side of the body. How come? Well, I'll give you a hint, and all of this is related to how different fibers are going to cross the midline at different levels through the central nervous system. Okay? So, in summary, you should be able to describe the internal anatomy of the cord using these terms that we described today. You should be able to tell me the relationships between the spinal cord segments and nerve roots with the vertebrae and intervertebral foramina. You should be able to list and describe the arrangement of the three meningeal layers around the cord and around the nerve roots. Explain the clinical importance of the lumbar cistern. We did talk about the vasculature of the spinal cord. We also described the anatomical, functional subdivisions of spinal nerve roots and spinal gray matter. And you should be able to outline the laminar organization of the spinal gray matter. Okay, so this marks the end of our lecture. So spend some time learning about the anatomy of the spinal cord, as this is going to form the basis for the next couple of lectures. Okay, so thank you for listening, and I will see you very soon.